Good afternoon, everybody on the Eastern Seaboard, and good morning for those in other parts of Australia. My name is Mark Stuve at the Burnet Institute. Welcome to today's presentation around Australia's progress towards hepatitis C elimination. For those that have arrived on time, thank you, but we might wait a minute or two for people to jump online if you just be patient. Okay, we've just ticked over 12 so we might get the session underway. Welcome everybody to this year's launch and presentation of Australia's progress towards hepatitis C elimination report. That's been prepared by a whole range of people around the country, but led by the Burnet Institute and the Kirby Institute, so welcome. This is our third report of a series that describes Australia's Australian data charting our progress towards hepatitis C elimination. It brings together a range of data from around the country, studies, surveillance programs, and essentially is oriented around the key pillars that will drive us towards hepatitis C elimination, largely aligned with those outlined by the WHO as part of their global sector strategy on viral hepatitis. Before going any further, I'd like to acknowledge the traditional owners of the land on which we are all gathering today and pay my respects to their elders, past, present and emerging. I'd also like to acknowledge all the people who have been affected by hepatitis C over the years, acknowledge the many people who have lost their lives to hepatitis C and liver disease more generally. And acknowledge those with lived experience who have contributed to research and program development in this space. People living with hepatitis C, those affected by hepatitis C, and those who have died from hepatitis C related disease are real people who have real lives and real experiences. They're people's mothers, fathers, children, uncles, aunties, and they all have brought a wealth of experience to help inform our program responses. So I'd really like to acknowledge all of those people who have been affected by hepatitis C over the many years of the epidemic. I'd like to do a bit of housekeeping and provide a bit of an overview of the session today. So we will be, first I'd like to, we'll be going over data highlights that are contained in this year's report that'll be presented by Anna Wilkinson. After that, we'll have a Q&A session. We have an excellent panel this afternoon after the data is presented that can reflect on where we're at in hepatitis C elimination across the sector in Australia. I'd like to remind people of who are part of the Twitterati that our Twitter handle is there on the screen, and please encourage you to use those hashtags as well when tweeting out responses to today's session. Also, where to find the final report. The final report is on both the Burnet and the Kirby websites, so please go to either of those to locate the report. And Also, in relation, you can reach out directly via email to that email address as well. Also, I'd like to remind people, I guess, that today is a scientific webinar specifically about hepatitis C. Some of the researchers that are presenting today and talking today have been working hard on other diseases of prominence in the community today. And there are certainly forums in which people can provide feedback or express concerns about those other areas of research that the Burnet or the Kirby or other players who are involved today are involved in. But for people to please restrict today's discussions and questions to those related to hepatitis C and the information that's presented today. Just like to give a bit of a welcome and an introduction to the people who will be speaking today. Firstly, our expert panel who will be participating in the Q&A session. We have Margaret Hellard, who's the Deputy Director of the Burnet Institute here in Melbourne. Greg Dorr, who's the Head of the Viral Hepatitis Clinical Research Program at the Kirby Institute at the University of New South Wales. Carrie Fowley, who's the CEO of Hepatitis Australia. Andrew Lloyd, who is Head of the Viral Immunology Systems Program at the Kirby Institute, again at the University of New South Wales. Troy Combo, who's a Program Manager at the University of Queensland and also Program Manager for the EC Australia Aboriginal Health Plan and a proud Bundjalung man of Northern New South Wales. Charles Henderson, who is Deputy CEO of the New South Wales Users and AIDS Association. And facilitating our Q&A session today will be Jackie Richmond, who is the EC Australia Workforce Development and Health Services Delivery Program Manager. And finally, I'd like to introduce and welcome and acknowledge Anna Wilkinson, who's a Senior Research Fellow and Data Analyst at the Burnet Institute, and most importantly is responsible for coordinating the enormous task of bringing all the data together for the elimination report that will be presented today. Anna will be providing an overview of data highlights contained in the report, and then we'll move through to the Q&A session. So, Anna, thanks.
Great, thanks Mark, and welcome and good afternoon everybody. Good morning for those who are here in the morning. I'm presenting today on Wurundjeri land, so I pay my respects to elders past and present. We're going to have a very quick run through some data today. The focus really is on your questions and a discussion point. So this is going to be just a quick tour through. I would first like to start by acknowledging the editors of the report and to thank them for their considerable contributions in bringing this report together. Today, we also have Lakshmi Manoharan joining us, and Lakshmi's also helped me prepare this report this year. So I'd like to say thank you to Lakshmi as well. We'd like to go through and say some thanks to people who have contributed data. As you may know, this report is really a collation of data, and it doesn't happen unless people generously give their data and also their time and answer a level of emails and questions from me that really borders on harassment. So I'd like to say thank you. So from Access, Jason Aslin and Michael Traeger, from the Stop C study, Bezard, from the Monitoring Treatment Uptake Project in Australia, also Bezard and Greg. From the Reach C project, thank you to Joanne Carson. From Atlas, thanks to Claire Bradley and her team at Atlas. I'd like to say thank you to Jenny Iverson and Lisa Ma from the Australian Needle Syringe Program Survey, Heather Valerio from the representing the Ethos Engage study. Thank you to Yumi Sheehan and Rebecca Winter from the National Prisons Hepatitis Network, Amy Kwong and Richard Gray for the Cascade work, Mandy Byrne from the Australian and New Zealand Liver and Intestinal Transplant Registry, Jen McLaughlin and Glenn Cowie from the Viral Hepatitis Mapping Project, Tim Brody and colleagues from the Stigma Indicators Monitoring Project, Martin Holt, Lee Min Mayo, and again, Tim from the Gay Community Periodic Survey, Amy Kwong again and Richard from the Burnet from the Kirby modelling work, and Nick Scott for the Burnet modelling work. So thank you very much to all of those people that have really generously given their data and their time so that this report does come together. So we're gonna, as I said, we'll have a quick whip through. We're gonna go through chapters 1 to 8. We're really just gonna pick out a little bit of data from each section to give a bit of a story, not favouring any data or recommending any data over others, but just to really give us something to think about and talk through today. So we're going to start with new infections in chapter 1. So this is data from the Access Sentinel Surveillance Network, and this is from primary care clinics, and these clinics are in Victoria, Western Australia and Queensland. So they provide specialist services to current or former people who inject drugs, but also general health services. We do need to think about who attends these clinics when we think about this data. So this is a measure called incidence, which is the rate of new infections. So how quickly people are getting a new hepatitis C infection over time. And we can really clearly see from this data a decline in new infections from 2016 onwards. So when we know direct acting antivirals were scaled up, we can see a resulting decline in new infections. So we're really starting with a good news story today. This is the data from the STOP-C study, which is a cohort study of prisoners. And at the halfway point of this study, treatment was actually scaled up in the participating prisons. So we can see a very clear decline from that midway point, again, in the rate of new infections. So this is also a good news story to get us started today and does tell us about the importance of scaling up treatment to prevent new infections in these two settings. So in primary care settings, which are in our community, and in our prisons. Understanding the trends in testing is, I think, really key when we're getting to this stage of the elimination, because we really do need to see people tested and diagnosed to then achieve those uptakes in treatment that we can see are actually giving us those reductions in new infections that we just saw. So all of those pieces need to come together, but starting with testing. So this data is from the same clinics that we saw in the first graph. So you have to think about who comes to these clinics. And this shows the number of people having an antibody test. So that's the bars, and the men are the darker color and the women are the lighter pink in this graph. So if you focus on looking at the bars, you can see there's a slight increase in the number of tests done, really 2017, 2018, 2019, which is what we would expect. And we do have less testing in 2020. So we probably expected this. This is probably our first look at some of this data to understand what happened, particularly in Victoria with COVID-19 related restrictions on testing. And we can see a bit of an absolute decline, so less testing happened. The proportion of tests is the line in the blue. So if you follow the lines in the blue, we can see that for the men, the proportion, which is the broken line, which sits up the top, it's about at least 1 in 4 to 1 in 5 men who have an antibody test tested positive. For women, it's lower, and that's probably to be expected. As a reminder, these are general health primary care clinics as well. So this does tell us perhaps a couple of things. One is that the positivity, so the amount of tests, people coming back positive, has slightly declined over time amongst men and women. And so it may be that less people in the community are being exposed to hepatitis C, but we do sort of start to ask ourselves questions as well about who is being tested, and perhaps there is some testing among those that might have a lower risk of hepatitis C, so they're not coming back positive. But we could look at the good news story, which is that perhaps less people are actually being exposed. For the first year, we have actually included data from sexual health clinics participating in Access. So this is data of testing, again, antibody testing among patients that were recorded in a patient management system as being Aboriginal, Torres Strait Islander, or both. This has been our really first look at this data to understand about indicators to monitoring progress to hepatitis C elimination. So we can see, if we focus on the bars, that from 2016, 17, 18, there was an increase in the number of people tested for hepatitis C antibody, which is a good thing. We do then have a decline in the more recent years. These clinics are more nationally spread than our first primary care clinics data. So we probably don't have as much of a pandemic effect. We will have some New South Wales and Victoria pandemic effect, but this might actually tell us that in these particular clinics, less Aboriginal and Torres Strait Islander patients are being tested. For the positivity in the blue, we can see generally a trend over time, again, in that declining of the proportion of people that are testing positive when they have an antibody test. The Atlas network features again in this year's report. So this is different to the data that I just presented from sexual health clinics. This is actually from data from Aboriginal community controlled health services. So a really important type of service to include in our report. So we can see it's quite similar to last year, our numbers. Of the people attending the clinics, we can see about 1 in 5 were antibody tested, and about 7% of those tested came back positive, and over half of those who came back antibody positive went on to have an RNA test. We're into chapter 3, which is now treatment, and I think we all know how important it is to have a think about our treatment numbers. So the monitoring treatment uptake project will be well known, I think, to most people here. So So this year, for the first time, we have the full PBS data set being used. So it's important to point out we have a bit of a difference between the data used in the years of the reports. So we can see from this data, which is really valuable, it gives us two things, which is our jurisdictional look. So what is the difference between jurisdictions in the number of people treated and the proportion of people treated and left to be treated? So if we look at our circles up the top, our dark red part of the circle tells us what proportion of people have been treated, and our lighter color tells us the remaining. So there is variation across jurisdictions. In general, I think it's fair to say that probably in most jurisdictions, we have about half of the people treated, so we still have half to go. This is also the monitoring treatment uptake project, but the key thing that we've updated for this year is that nurse practitioners are included in this data. So we can start to see the contribution of nurse practitioners to treatment initiations. I think this well-known decline is now been seen by most people, so that we know we have declining treatment numbers. So notably for 2020, this is the first time since 2016, we actually had less than 10,000 people treated in a year. We have again for this year's report data from the National Prisons Hepatitis Network on in-prison hepatitis C treatment. We've put together the two pieces of data, which is the PBS data, which I just showed you, as well as the in-prison treatment program data. So this gives us a really nice way to think about what is the contribution of in-prison hepatitis C programs to overall treatment numbers. And we can see, looking at the most populous states first, that prisons are really pulling their weight when it comes to the number of people treated overall that we have. So we have from these jurisdictions, about a third to a half of all the treatments done in 2020 were coming from an in-prison treatment program, which is really nice to see. We have looking at the smaller jurisdictions now, so we're still looking at the in-prison treatment program data. We can see that even the smaller jurisdictions, they're making considerable contributions to the overall number of people treated in 2020. So I think this is a really positive story from this year's report to see how the treatment programs were really able to maintain their work amidst the pandemic in 2020. I think the questions that we've been asking ourselves last year and this year, and I know the National Prisons Hepatitis Network are working very hard on collating perhaps some additional data and consistent data so we could start talking about testing as well as treatment in the in-prison treatment programs. To finish this treatment chapter, we have the National Cascade. So this is estimated annually as part of the annual surveillance report. In the current Cascade, there remains to the end of 2020 an estimated about 117,800 people still living with hepatitis C at the end of 2020. There's some work here that we can always see. I think we've seen this before in lifting, really, I think those are the proportion diagnosed and the proportion having those RNA confirmed diagnosis. For the 2020 report, I think we also find ourselves once again thinking about how do we address the gap in data on the longer term outcomes of hepatitis C or averted outcomes due to hepatitis C testing and treatment. This really remains a challenge for us and the challenge for the report to fill out this knowledge and this gap in data here. We do, however, have the Australian and New Zealand liver and intestinal transplant registry data. Similarly to last year, we can see down the bottom in that dark red, the decline in the hepatitis C related cirrhosis as a primary diagnosis for transplant recipients. These are just Australian transplant recipients, by the way. I told you we were going to fly through, so hang in there. We're going to get to the chat soon. So the report really continues to have a separate chapter on stigma and discrimination, because I think we all acknowledge that this is really something we do need to monitor alongside some of those biomedical outcomes if we're thinking about progress to elimination, because I think we all want to think about progress to eliminating stigma as well. So the Stigma Indicators Monitoring Project surveyed healthcare workers in 2021, and there remains reports of expressed stigma towards people because of their hepatitis C status. From the same project, however, this is from a survey of the healthcare workers, but this is reporting stigma towards people because of their injecting drug use status. We can really clearly see that that is an increased proportion of people that would express stigma towards someone because of their injecting drug use status. The data isn't there to create a comparison between 2018 and 2021. They use different recruitment methods. But I do think it's really important to think about, there is a take-home message here that if we don't start thinking thinking about addressing the causes of not accessing healthcare, then we're unlikely to achieve what we just showed in the previous graphs, which is that lifting of testing and treatment. So primary prevention remains a really key activity of a comprehensive public health response to hepatitis C. The good news here, I think, particularly in the pandemic conditions of 2020, is that respondents to the Australian Needle Syringe Program survey reported similar rates of reuse of someone else's needle and syringes. We do note, however, that the survey was not able to be done in Victoria this year. So that's a gap in the knowledge. We probably don't understand what happened in Victoria, but I think it is still a really good news story that we are able to maintain that level of primary prevention. As we really, I think, move into the a new or additional phase of elimination where we start thinking about who are the remaining people left to be tested and treated, I think considering geographical equity and access to testing and treatment really comes to the fore. So we can see from the viral hepatitis mapping project that in no way is access to treatment the same across jurisdictions. I think importantly, though, it's good to think about this data perhaps in a different way, which is if there are jurisdictions and areas that have done really well, how do we find out what they did? How do we scale up what they did? So I think there's two parts to this map when I look at it, is what's the good news story? What can we take away? What can we scale up? And who are we leaving behind? And what do we need to do about that? Last chapter, folks. So I suggest you have a think about your questions because we're going to move straight to Q&A after this. So get your questions ready to go. Modelling from colleagues at the Kirby Institute show how we are tracking towards hepatitis C elimination. So this work projects that if annual treatment numbers are maintained at an intermediate scenario, so that's at about approximately 8,000 people treated every year each year, then we will achieve the treatment coverage and the incidence reduction goals by 2028. And we're finishing today on some modelling from the Burnet Institute on the case for investing in hepatitis C testing and treatment. So this figure shows that the initial cost of scaling up testing and treatment, so putting in more investment, puts us a little bit in the red. However, very quickly by 2022, the investment becomes cost saving. So if Australia could really arrest those falling testing and treatment numbers, really continue and push for an effort to get people tested and treated right through to 2030, then it is estimated that this will prevent 10,000 new infections, save 930 lives, and have an economic benefit of $272 million. Thank you everyone for listening through the figures. I know that's not everybody's thing, so we want to quickly move on to getting some questions and some discussion. So I'm going to hand to my colleague, Jackie Richmond, who's going to chair our Q&A today. Thanks, Jackie.
Thank you, Anna, and thank you very much for once again a very eloquent overview of lots of graphs, which I've learned to love because you've taught me how to love them. So thank you very much. I welcome the panel who were previously introduced. So we've got Margaret and Carrie, Greg, Andrew, Troy, and Charles. Charles, can you give us your face because we can't quite see it. Please feel free to, I can see there are some questions coming in. I'm going to take a liberty just now. So a little insight firstly into my life. So for the last 15 years, I go to a fish shop at my local market. And because I see every interaction as an opportunity for raising awareness, my fishmongers are very well aware of what I do for a living. They call me the Queen of Hepatitis. And it's the only place that I get this type of respect. But when they see me coming, they call out, here comes the Queen, here comes the Queen of Hepatitis. So in my local market, I've had many, many wonderful opportunities because they scream it out so loud that people go, what's that hepatitis? So it's a great educational opportunity. But let's just for a moment, I want you to all think on the panel. You're the king or queen of hepatitis. We're heading towards elimination. What do we still need to do to reach this goal by 2030? Margaret, I'm going to start with you and then I'm going to ask Charles.
For me, really simply, Jackie, is to make it clear to people that we have wonderful treatment and that we would like to treat anybody, but we need to ensure we're engaging with key communities so that they're aware of that and that they're linked to testing and care in a way that works for them. And so I think we are in a phase of elimination where it's not just for those that storm through the door, the willing and ready. We've now got a group of people where we really need to think about who they might be and then make sure that we're tailoring our efforts to them. So I think it's an engagement issue, but understanding that this is a group of people who are not necessarily, Hep C is not front of mind, but they are prepared to get treatment. We just have to say, how do we engage with you in a time, place, space that works for you?
I think we're seeing lots of examples of that type of innovation, aren't we? Where, as a nurse, I refer to that as person-centered care, where we go where the people are and deliver care in the way that people want it. Charles, what do you think we still need to do?
Thanks, Jackie. Look, engagement, I think, is absolutely right, Margaret. Doubling down on some really key points and taking the learnings that we've got from a report such as this is really important. And in engagement, we really need to start bringing in peer-led models on prevention, testing and treatment. So let's really make sure that the whole gambit is addressed through peer-led models. And peer-led models by design need partnership. And if we're going to be effective at the prevention and testing side of things, we need those really clear, low threshold, low barrier pathways to treatment. And that's really, really quite fundamental. We need to make sure that people are understanding how to engage in treatment and how to engage in low barrier testing. What else? I think we need to be really aware of language and stigma and discrimination, I think, being mentioned in the report is really key. I think there's still a real lack of understanding of what stigma might be and how the resulting discrimination can affect people affected by hepatitis C. Addressing the peer issue itself, understanding that peers come in all shapes and sizes, but I think the elimination targets do really need to be focused on peers that are connected to people who are injecting drugs community as peers. So because hepatitis C affects people who inject drugs quite predominantly as a virus, that's where we need to really start focusing in on what we've got to do. And to understand that access to healthcare remains the critical point, and nothing will get done unless we address that. But we can address that through peer models, and connecting and partnering with innovation and with peers will really reduce those barriers and increase that facilitation towards the aims of 2028 and elimination.
Thank you, Charles. My newly anointed king and queen of Margaret of hepatitis. I'll share the title. I'm okay with that. Anybody else want to make a comment on what still needs to be done? Greg?
So I think we need to sort of find out why people haven't come forward for therapy. I mean, I'm often asked, who are these people? Where are they? But the question I'd like sort of answered is, probably in a qualitative sense, is why people haven't come forward and what's required to provide the circumstances and the environment for them to take up the opportunity of Hep C therapy. So fair bit of qualitative research in that area, I think would be really interesting.
It's a really, really great point. Let's not guess. Nobody else, anything? Just picking up on what Charles just said, I mean, we all know, and it's wonderful to see stigma and discrimination included in a surveillance report like this. Somebody's asked that it looks like the stigma has increased into 2020. What might be some of the reasons behind the increase in the stigma? I do note here that Anna flagged that the data sources were slightly different between, was it 2019 and 2020? But anybody got anything to comment on there with regards? Yeah, Charles.
Well, it relates to what Greg's saying too, and it's those structural and wider social and health and economic determinants that cause the barriers, and the criminalisation issue is major. Whilst we're really successful in prisons, you know, that's a fantastic in itself issue around hepatitis C. It's a fantastic result, but it's kind of sad to realise that we're gathering people through a situation like incarceration, and we need to be really mindful. I need to mention it, and I know everyone knows this, of how we deal with people as they come into the community. But it's those determinants issues, it's the structural and community issues that are so embedded in people's thinking around the war on drugs, that they just don't think anything but being down on someone who might use drugs or who might inject drugs. And that's a norm that is so entrenched in our community, in our society, that it does behoove us to all get into addressing that very issue and saying, no, this is not to happen. This isn't right. And it's just wrong on so many levels. So we maybe need to connect the hepatitis C elimination issues to a human rights issue, perhaps.
Just to add to that, Jackie, I mean, I think it's interesting to think of whether the COVID era is going to have any sort of impact or has had an impact. And there's a general level of fear and anxiety within the community. And I think if you've only got to look at the way that Australians have been treated as a marginalised population to understand how already marginalised and vulnerable populations, how they may do in the context of greater sort of fear and anxiety of the other, in a sense. So whether that has had any sort of impact or influence on the way that we look at vulnerable populations.
Yeah, absolutely. It's a very good point. We need to learn, don't we? Learn from what we've been living and not see them as isolated incidents. Thank you, Charles, also for that really important response to the unfortunate increases, but we all have a role to play, don't we, in calling out stigma and discrimination. Carrie.
I just wanted to, I agree completely, Charles. I guess highlight an opportunity in terms of thinking about the future, noting that our national strategies are up for refresh next year, and it's a really critical time for us to be thinking about what could be the next lot of policy levers that we need in place. And one example of that, building on stigma, is to think about structural indicators. How are we thinking about health systems and accountabilities within the systems, not just at a kind of individual kind of self-report level, but also at a systems kind of accountability level?
Another, Margaret, yeah, another. Really
yeah, I want to totally agree with that, Carrie. I think it's super important that in all levels of the system, we're trying to say, are we designing the system to suit the people? So as well as the systems levels, to think about what that means. And to me, that taking care to the locations that work for the people that we're wanting to treat, to simplify it, to actually have a real acceptance that the system is not built for us who work in the system. The system should be being built for people who we're trying to reach. And so we need to think about what's the structure of our systems as well as the stigma, but actually restructure them to be more appropriate for what we're trying to achieve for the individual. So I think there's a whole series of things that we build systems to suit ourselves rather than people we're trying to provide care for. And we need to really think about that in the next components of the strategies.
And I think our health system has shown that it can change and it can move and it can adapt. So we've got to keep that feeling alive, don't we? Troy, just to bring you in, I'm just wondering, do you think we have enough information to understand how we're progressing in terms of elimination and what we need to do further for Aboriginal and Torres Strait Islander people.
Yeah, thank you, Jackie. I'd just like to start just by framing this in two contexts, I guess, and one is in the context of dealing with inequity that Aboriginal Australians face within Australian society. Understanding and acknowledging the impact of colonisation and that racism does exist not only in Australian society but more so across the health system. And look at the inequities in access to healthcare, but also we look at the high rates of hepatitis C, especially around new incidents that still increase in Aboriginal communities, and really understanding the impact that the overrepresentation of Aboriginal people and social justice has on Aboriginal people in Australia. So I think that's firstly the really important factor, and secondly is more of a current one, and this threat of COVID-19 and the impact that it can have on Aboriginal communities, especially grappling with a high rate of anti-vaxxers and anti-vaccine sentiment within the Aboriginal communities. I think it's really having an impact on trying to get some traction in this space and working with our services and our communities, especially when we're locking people out of communities. And also a lot of Aboriginal community child health services have put moratoriums on new partnerships or new research to be undertaken in this space as well. So just a couple of the factors that I think really impact, but more around the data, I think that we do need to improve our surveillance and monitoring systems of hepatitis C, especially around the old one, which is just increasing Aboriginal status and identification of Aboriginal people within patient information management systems, but also across the pathology and laboratory services as well. And an understanding of the viral distribution of hepatitis C in Aboriginal communities and where we need to focus our energies. If you have a read of the Doherty and the World Health Organization mapping report, there's no mention or stratification of Aboriginal people within the hepatitis C component. There's lots of mention within hepatitis B, but we don't understand, by primary health network boundaries where hepatitis C actually is. We need, I think, more readily available treatment uptake data, so uptake of treatment for Aboriginal people, without having to undertake, large data linkage programs to sort of get access to this data. And also, at a service level, increase our number of Aboriginal community child health services that are participating within the Atlas network and enrol new services into that. And also, as we get better data within the access, also having a look at what's happening across the primary healthcare services and sexual health clinics as well. And we see for the first time, we'll be able to present some data on that this year. So yeah, that's all I think, and just support for our Aboriginal community child health services at a service level to produce better, baseline data and understanding of their data, and have data more at hand in real time for them to be able to incorporate that into CQI activities and increase testing and treatment uptake.
Absolutely. Thank you, Troy. I think there are some themes coming out, aren't there, that we're all very well aware of. It's innovation, but ensuring that you understand the community and their needs. In terms of, I've got a question here. So the WHO and FIND are leading Hep C self-testing studies, mainly in low and middle income countries. Does the panel see that self-testing may play a role in Australia? And what do you think needs to be considered in an Australian context? Does anyone want to take the issue of self-testing? I'm going to pick Margaret. I was going to pick on you anyway, so that's beautiful. Thank you.
Look, I mean, I never understand anxiety around self-testing. As I say to people, the test that 50% of, well, not 50%, but a significant proportion of the population take, it is probably the most life-changing self-test, is done, which is a pregnancy test. And at the time when people will forget this, but when pregnancy tests were first introduced, from what I understand when I've talked to people about it, the anxiety by health professionals about women testing to see at home whether they would be pregnant and what would they do with such a result and how would they interpret such a result, and the sky was going to fall in. And, we all know, well, we don't all know, all of the females, many of the females on this call will know it is a pretty simple thing to do when you self-test at home, and then you have this life-changing sexually transmitted infection is what I always say. and it's with you for life, like forever. I just think that if 50% of us can manage it, I have great respect for the males in our population, that they too will be able to manage the complexities of self-testing. So I've never understood the anxiety around it. For me, the thing that I think is really interesting and a thing that would be lovely to solve is there a way of capturing the test result? And I know that that might be really difficult, but I'm confident that there'll be a way. It's in my view, it's better to self-test and us not know about the negative test results, but have somebody self-test regularly and then them linked to care with the positive test than to not have it at all. So over the years, I'd like us to think through whether there's a way of capturing it, but if not, I would just prefer self-testing was available, affordable, available to all.
Thank you, Margaret. So, I mean, if we think about what is actually happening and what's happening very soon, and that is the rollout of the national point of care testing trial around Australia through the Kirby. So, Greg, I'm interested. How are we going to? Margaret's intimated this with self-testing. How are we going to capture this point of care testing data and integrate it, and then understand how it's impacting on our progress towards elimination?
Thanks, Jackie. Yeah, that's a lot to sort of do, so to speak, in terms of that sort of broad area of connectivity. So how do you go from a sort of finger prick of blood that demonstrates that you're maybe antibody positive or antibody and RNA positive, and how does that sort of fit into the public health systems and notification system, and how does it sort of interface with the clinical care sort of setting? So there's still work to do in terms of that connectivity to develop systems that allow those positive results, particularly on the RNA sort of side, to then go through the notification sort of system. So the last thing we want really is that every result would need to be confirmed. I mean, that would seem to sort of, not utilise the sort of benefits of having sort of point of care rapid results to require then sort of a further sort of test. And in the sort of Tempo pilot study, we did everything through a finger prick. We did HIV and Hep B serology as well. So that's the sort of beauty of a simplified assessment sort of system. So we just need to develop the systems, and Jason Grebley sort of spending many hours sort of on this. And there's a lot of education and training, obviously. Flinders University is sort of involved in that. So the program will not only roll out these machines, but help sort out those aspects of the testing and how you link to public health surveillance systems and the clinical sort of care requirements that flow from it. But I'm very optimistic that in a year or so we'll have all this sort of sorted and things will be much more simplified.
It's certainly is exciting times, and I mean, speaking of exciting, Andrew, you're the really the positive. Aside from those incident numbers going down, you're setting the prisons. You are really the backbone of our hepatitis C elimination efforts. What else needs to be done, Andrew? I've got a note here from Northern Territory just noting that their prison treatment rates are lower than perhaps they'd like them to be. What are you thinking? What are you planning?
So Jackie, thinking about all of the discussion that's happened and framing the role of the prisons in relation to our ongoing elimination efforts, it's sort of, as you flagged and Charles flagged, it's a sort of a sad story. We have a high incarceration rate, but then there's an opportunity for better or for worse, both for Indigenous and white communities in the prison setting to facilitate access to testing and treatment. And there's just a heap of great work being done around the country to get the health systems in place for hepatitis testing and treatment in the prisons. But if we think about it as along the lines of who should we be focusing on, where should we be doing this to focus our elimination efforts, and how should we do it, which each one of the speakers has already flagged. So the prisons offers an opportunity to target the higher risk population, that is people who inject drugs. So it focuses the attention very well. And for better or for worse, it focuses attention on both a high prevalence and a high incidence setting, and both of those things matter for our elimination efforts. And so the prisons meet the who and the where question as being a good opportunity. I do think we've still got more work to be done in the how, though. So not illustrated in the report, but we are broadly aware that of all the people who come into prison who are identified as having chronic hepatitis C and engaged in testing and treatment, it really still is probably only a significant minority of all those who actually come into prison in a year with chronic hepatitis C. So that says, well, you're doing well, team, but actually there's definitely more to be done. And some of that relates to the points that others have made about taking or maximizing the system to benefit or to orient to the clients, to the patients. And so even in the prison, it's absolutely clear that there are significant subsets of individuals who aren't or won't coming forwards for testing and treatment. And so there's definitely more to be done to overcome residual stigma, barriers, organizational structural barriers. Definitely more to be done in stopping the loss to follow up in the care cascade. And that's about simplification of testing and treatment pathways. And the project that you flagged that Greg was talking about, the point of care project, it's definitely got a number of prison sites that are on the plans. And so those are great opportunities. And perhaps one other thing I wouldn't mind to flag would be, so I think there's plenty to be done in the prison sector. And I think our expectations of the sector should be to continue to contribute heavily going to elimination. There are other, what you might call foci, venues in which effort could also be put, which I think at the moment are maybe largely untouched. And one that comes to mind is the community correction space. So that's individuals who are not in prison, but may have been previously in prison and now on parole, or the courts have told them to stay under regular supervision. So community corrections fall under the jurisdiction of correctional authorities, but actually they're not healthcare venues. And as far as we know from the limited data available, they're not really, they're a group that are really not accessing testing and treatment either at all or very much through mainstream community services. So that sounds to me like a window of opportunity, and that the population size of those on community corrections is almost double that of those in prison. So we think there's more work to be done in that space. There are probably others, but they look like efficient, high value for money and effort venues.
Thanks, Andrew. And it's a lovely segue because we know that our colleagues at Hepatitis Queensland have got some great work going on there, of which I wear their earrings today. They're liver earrings, so please feel free to go and purchase some liver earrings. They are putting that money towards covering co-payments for people in that community corrections project for the DAAs. Margaret, you wanted
just wanted to pick up on that point that Andrew made, and again thinking about, you know, where are people and how do we do that? I think that community correction setting is critically important. Similarly, work that, say, Joe Doyle and others did, we did as part of a study called Pharmacy, where people accessing the pharmacies, we know that that's worked very well as well for COVID vaccinations and stuff. Where people go for their broader healthcare or other needs are places where I think we can be setting up to provide access to care and care if that's the most appropriate place. So either an entree to care or the actual care. Similarly, we talk about mental health. We know a significant proportion of people with mental health issues, when we've looked at it, are not in hospitals, but in community settings where, again, they're accessing it. So I think there's a lot of opportunities where we're not providing an entree to care, or where people actually go, where it makes it easy for them so they don't have to go to multiple places. Again, it's that taking it to where people are, be it the community corrections, be it pharmacies, be it community-based mental health settings. To me, it's this sort of looking across always at where are people going for either a healthcare need, which is light touch, but overrepresent, like more likely to have somebody overrepresented with hepatitis C, or a non-healthcare need, a broader social health need, where you can also sort of say, can we embed here and work with those services? So I think we have to be really thoughtful and imaginative to make it simple, again, simple for people. You don't have to go somewhere new to get this done.
And I think, Margaret, we really recognise too, don't we, that it's not just about, build it and they will come. So, it's the role of that engagement and Charles, you certainly flagged earlier, the role of peers. And I've got a question here that, there are many peer worker programs that have now been evaluated, that have been shown to be very effective in terms of being that first point of contact, bringing people in to a system, creating a system that is safe, and addressing and sort of helping to overcome some of those issues of discrimination. I mean, what can we do more in this area? Is there a role, peers in prisons as well? Charles and Andrew, do you have comments?
I'll start. I mean, for instance, we've started a great partnership with Corrections, Justice Health in New South Wales and Newer, where we call it FRI, which is peer harm reduction in the yard. So we're really down and fat and pH fat. So it's a really great, it's a harm reduction based education program where we're getting small groups of
Is that Charles first?
corrections.
Oh, exactly.
It works really well, and we've done a pilot on that. It's been very successful. We're going to go to a women's prison in 2022. I guess peer-run programs. I would actually say that for successful elimination, we need to be peer-led. And when we understand the context of hepatitis C in relation to people who inject drugs, we get to understand that memories get very much entrenched in people who use drugs' minds. So they see that 10 years ago, they were effectively excluded. Pre-DAA, there was a lot of exclusionary type policies based on cost, based on thought, based on politic, that dissuaded people who injected drugs from engaging in hepatitis C. These communities are very intermingled and very mixed, and those that have memories of then are passing those sort of comments through to the people of now. So when we say peer-led, people who inject drugs whose work that's got a focus on hepatitis C, it means that by engaging that way, we're engaging through the principles of harm reduction, which are empathy, connection, and support. And through that, it's not so much a championing of the service that we might be partnering with, but it's about endorsing that system will see you right and will be with you through in addressing your health needs right through to SVR. And as Margaret rightly points out, a wider healthcare focus is absolutely the way to go, including mental health. So that applies whether it be self-testing, whether it be low barrier testing, point of care testing, through to low barrier treatment. DAAs are just wondrous in that affair, but also around issues to do with prevention. So when we understand that the journey of using drugs and being infected by hepatitis C, we need to just get rid of some of these paradigms around even reinfection. We just need to understand and get people that are on the journey of using drugs a little bit more integrated with the healthcare we're being offered, and that has to be peer-led.
Absolutely.
If I could just build on
Harry,
that.
yes.
I think just building on what Charles is talking about in terms of really taking a health equity lens in terms of the work going forward. And I'm thoughtful of the work coming out of New Zealand in terms of the framing through their BBV STI strategies that really is framed from a health equity kind of perspective. And I guess just to loop back to the report of highlighting some of the geographic equity issues that we've got in terms of the response, that it's really important that we make sure that the elimination efforts are equitably accessible to people across the country. And we really need to look at where we've got some really high prevalence PHN areas that are not in metropolitan areas. So, and I don't think we should take for granted that people actually know what's available and what's possible. And I guess also just to flag, also building on Charles's point about needing a full spectrum of responses to make sure we're talking about prevention, harm reduction, testing, treatment, diagnosis, care, but also talking about post-cure care and support. So linking in also with the report in terms of things like cancer and how hepatitis elimination is essentially cancer prevention work. So just because people engage in cure doesn't mean we let them go. We've got to hold and stay with them in whatever ways that is best to them. And then also, I guess, linking with that is we've got a major gap in our strategies where we don't have quality of life indicators. And that's really critical of moving kind of beyond the incidence lens to a broader kind of whole of person perspective over their life course.
Thank you, Carrie. And I think a great way for us to end this discussion, I apologise to the people who asked those questions, fabulous questions. 25 minutes just goes by in a flash. As I found the last couple of years have actually gone by in a flash as I've sat in my house basically for 2 years. I look forward to hopefully seeing you all in person at some stage, and we can further nut out all of these big issues that we have ahead of us. Over to you, Mark.
The perennial problem of coming off mute. Thank you, Jackie, and thank you to all the panellists for the discussion today. It was an excellent discussion post the presentation of the data. I'd like to acknowledge our funders of EC Australia, the Paul Ramsay Foundation, who have made a very generous contribution to the EC Australia program that has helped support the development of this report, and obviously our colleagues at the Kirby Institute at the University of New South Wales and my colleagues at the Burnet Institute for pulling this report together, and all of the contributors in relation to data provision and for support in editing the report. I think the sector feels that it's a very important document, and it really helps us understand where we're at in Australia in the elimination efforts. I'd also just like to acknowledge many of the people online today and the sector in general, including the affected population, on the amazing achievements over the last 5 years or so in the DAA era. When these drugs landed, it was transformational, and I'd like to congratulate the Commonwealth Government at the time for putting these drugs on the PBS and making them broadly available to everybody who is chronically infected with hepatitis C, regardless of ongoing risk. The provision of the listing that allowed these drugs to be provided in prisons as well, and through the primary care sector. A lot of other parts of the world do not have that luxury of the type of access to DAAs that we have in Australia, and it really underpins our elimination efforts. So it's been an incredible effort, but there's a long way to go. And I think the data that we've presented today and some of the discussions that we've had today indicate that, that the next phase will be harder. We've treated a lot of people over the last 5 years, and it's been an incredible success. But where we go from here into the next phase of elimination will be challenging. We heard today around technology-based solutions that include rapid testing and self-tests. And these are really, really important innovations that provide us opportunities to present service models in different locations that are considered safe and more likely to be free of stigma. We've heard from panellists around the type of places that we might be able to integrate testing and treatment, including community corrections, opioid agonist therapy dispensing, mental health programs, and obviously in Aboriginal and Torres Strait Islander community health services as well. We need to go where the people are, and we need to present models of care, as Margaret said at one point, that are acceptable to the community, and we need to be designing those models of care for the community, and with their needs in mind, while delivering services that are sort of feasible and sustainable, and that are going to give us really high coverage. So I'd just like to end on that as sort of my précis for today and where we're off to now in terms of our next phase of elimination, and acknowledge everybody who contributed to the report, and I'd like to do one last shout out to Dr. Anna Wilkinson, who's done an incredible effort in pulling this together, herding the cats nationally, and pulling together yet another great report, the third in the series. And we welcome preparations for our next report next year, and hope to see significant ongoing progress in our efforts to end hepatitis C as a public health threat in Australia. So thank you all for joining us today, and we'll all see you soon.
Thank you.